Good afternoon. I'm Rebecca Garcia, Chief Prevention and Communications Officer for CPRIT, and I am joined this afternoon by Ramona Magid, Senior Program Manager for Prevention. And this afternoon we are discussing our new RFA for fiscal year 18-2 for the prevention program. So this RFA is for the delivery of evidence-based prevention services and not for research. So if you are a researcher or a company hoping to learn about some funding opportunities, we will not be discussing those today. We are just discussing one funding opportunity out of the prevention program, but CPRIT does have other funding opportunities for researchers and companies, and we invite you to look at those on our website. So with that, I'm going to go ahead and get started. And I think some of you know we have two funding cycles for prevention. The first funding cycle is well underway, and those results will be presented to our Oversight Committee in February. For the second funding cycle, we have released the 4 RFAs that you see on the screen. And this afternoon, we're just going to be discussing the new RFA, Expansion of Cancer Prevention Services to Rural and Medically Underserved Populations. The other 3 you should be fairly familiar with if you've applied or looked at our website for prevention funding opportunities. So the evidence-based cancer prevention services funding opportunity we've offered for some time, and that one this time will be for new evidence-based prevention service topics or those that have been previously funded with a contract end date before September 2016. The tobacco control and lung cancer screening RFA is also open, and the dissemination of CPRIT-funded cancer control interventions is now continuously open, so you can apply to that one at any time. So we are going to focus on the new one, but at the end of this presentation, if you have any questions about the other 3, we'll be happy to address those as well. So the goals of this new mechanism are to support the expansion of evidence-based services into populations that don't have adequate access to prevention. We also want to bring together networks of public health and community partners to carry out these programs that really meet the needs of their community. And with this mechanism, with this RFA, we also want to leverage the infrastructure and the networks and the resources that have been put in place by CPRIT-funded projects, because we really want to minimize startup time and leverage what has been already funded. And in addition, this RFA really addresses all of the program priorities for the prevention program. And as you may be aware from having looked at the RFA, that those priorities are to address populations and geographic areas of the state that are disproportionately affected by cancer. And of course, we focus on underserved populations, on the under and uninsured. So with this mechanism, a key part of it is that you must propose to expand a current project or one that was recently funded. And the expansion would include the addition of different clinical services, additional types of clinical services, and or the expansion to additional counties as defined by rural and medically underserved counties. So in the RFA, we put these maps in there, but importantly, we put the links to the maps in there because we know they're going to be hard to read. So when you're looking at expansion, it should be to non-metropolitan counties as shown on this map, or to medically underserved counties as shown on this map. And again, these are going to be hard to see both in this presentation and in the print document, but they're links so that you can really go to those links and identify the counties that are either underserved, medically underserved, or considered rural. So the required components of the RFA are as follows. Of course, it has to include expansion that we just talked about. And the expansion of the clinical services are screening for breast, cervical, colorectal, hepatitis C virus screening, screening for genetic risk factors, or vaccinations against HPV and hepatitis B virus. So those are the clinical services that are eligible under this RFA to be considered for expansion. And then we just talked about the other component of expansion, which is to the medically underserved and rural counties. They should be comprehensive projects, and this includes making sure that there's a continuum of services and systems and policy changes. So it should include things like public and professional education, outreach to the population, the actual delivery of the service, follow-up navigation, data collection, and very importantly, don't forget systems improvement. So you should propose comprehensive projects along that continuum. Of course, they should be evidence-based. This is a key principle of all of our mechanisms. They should be based on the existing body of knowledge about the evidence for cancer prevention interventions, and they should comply with established and current national guidelines. We also encourage the coordination of clinical service and community partners. So there should be a collaboration of clinical service providers and community partners that can help deliver that continuum of service, deliver the continuum of outreach, education, clinical service delivery, and navigation to services. And here's where it's really helpful, important to have letters of commitment or memorandums of understanding describing the role of those partners. And again, we do want to leverage the infrastructure and these existing networks that you may have through your CPRIT funded grants and other resources. And so it's good to describe how you plan to leverage what has previously been funded through CPRIT. And then lastly, one of the components is project coordination and technical assistance. So the overall program should be directed by a program director who's responsible for establishing and managing this network of partners. So the program director is responsible for any necessary subcontracts or memorandums of understanding, responsible for regularly communicating with the partners and meeting all reporting requirements. And CPRIT does expect measurable outcomes, such as a significant increase over the baseline for the services you're proposing, changes in provider practice, changes in system improvement, and cost effectiveness. And this may not apply in all cases, but in cases where it does apply and you have a network of clinical providers, you should establish standard protocols for all the clinical providers in the network, as well as standard policies and procedures for participating. So for this mechanism, we are limiting the eligibility requirements, and those eligibility requirements are spelled out in the RFA, but they're for those who have currently funded CPRIT prevention projects and those that had a contract date in fiscal year 2017. So that would be the time period between 2016 of September and August 2017. And that's because we really want to leverage what's been funded. Again, those networks and infrastructures that you've already established, but we want to encourage expansion and minimize startup time. So if you don't fall within this eligibility criteria, don't worry, we do have those other funding opportunities available for you that I mentioned at the beginning. So who is not eligible? The continuation of currently funded projects. If you are proposing just to continue doing exactly the same thing, that is not eligible here. It must include one of the components of expansion that we talked about. If you're proposing a tobacco prevention lung cancer screening project, we do have that separate mechanism, and for now, you should apply to that mechanism if you're proposing to do something in tobacco cessation, tobacco prevention, or lung cancer screening. If you have a new project, there is the evidence-based services RFA that you should apply to. You're not eligible for this one. And also, projects with a contract end date before September 2016 should apply to our other mechanism, the evidence-based services prevention RFA. So that is a brief overview of the mechanism itself. Just to refresh on the review process, it is a multi-stage review process. The first step is review by experts in the field from outside of the state of Texas. They will review each application based on its individual merit, not comparing it with other applications. And they will present their scores to the Programmatic Review Committee, Programmatic Review Council, made up of the chairs of those panels. And then at that level, at Programmatic Review, they consider things like geographic distribution of what's already in our portfolio, and where the greatest needs appear to be, type of cancer, type of program, and impact, return on investment, meaning how many people this project can address and can serve. The recommendations of the Prevention Review Council then go on to a Program Integration Committee, who is charged with looking at CPRIT's overall grant portfolio for research, prevention, and product development, and looking at the budget available. And then their recommendations go to the Oversight Committee, who then approve grant recommendations. So the peer review evaluation criteria are really well detailed in the RFA, and so I'm not going to go through that, but if you look in the RFA, there's questions under each one of these criteria, and these are the questions that our reviewers consider when they're doing their evaluation, and these questions are put into a template for reviewers as they try to see how these questions are answered by the applicant. So pay close attention to those when you are writing your RFA and make sure you address those questions. So with that, I'm going to turn it over to Ramona, and she's going to go over some of the lessons learned from the peer review process, and she's going to be your contact person for any additional questions after this, because I'm really prohibited from talking to individual applicants once our RFAs are open. We can answer questions in a group setting like this, but any individual questions, and we do welcome those, should go to Ramona after this.
And before I get started with that, I want to remind you that you can go ahead and submit your questions, and they will all be through the GoToWebinar control panel. You would click on the questions at the bottom right hand and type in your question and click send. And your question will be queued up with the others, and I will be reading your question aloud, and then either Becky or I or both of us will answer your questions. So please don't wait. If you have a burning question, go ahead and type it in now, and we will get to them as soon as I finish up with the presentation, and we'll have lots of time for your questions. So as Becky mentioned, these are some, we call them pitfalls and pearls. They're things that we've observed when we're listening to the peer reviewers, some things the reviewers have brought to our attention specifically. And so we ask that you pay close attention to these because we know they're important to the reviewers. So I'll just go through them, and we can take your questions on them later. So you should explain and reference the evidence base of the project that you're proposing, and you should also describe the innovative aspects of the project, as well as a fully developed evaluation plan. And you must also include meaningful and measurable outcome objectives. And it's highly recommended that you include any evaluation personnel at the beginning of your application process rather than waiting until the end or after they've been funded to bring them in on the project. Some things that applicants often forget to do is tout your success and what you're able to do, and make sure you discuss your staff people and how they've been valuable to the project and essential for the project. When possible, you should always include baseline data, and all of you for this mechanism should have baseline data because you've had a previous project. So don't forget to include that. And when you're setting your objectives, we need them to be very specific and measurable. So you would say from X% to Y%. So that's something that some people often overlook. So be sure to make them measurable. And in the back of the RFA, there's a document about writing good measurable objectives. And one thing the reviewers like to hone in on right away is looking for the place in the application that talks about ensuring access to treatment if you're offering screening, because you must prove that you have a reliable source of access to treatment in order to be eligible to be funded by CPRIT. We don't want to screen people with screening and diagnostic tests and then not be able to get them into treatment if necessary. Continuing on, we often get questions about integration and capacity building. This is about sustainability. So you should talk about your plans for systems improvements that would be sustainable over time, and definitely talk about the pieces of your project that could continue and be integrated into the organization after CPRIT support ends. We realize that projects in their entirety may not be able to be fully extended once CPRIT funding ends, but there are definitely pieces that should be able to be continued. And one example that is often used is, the training of personnel, say community health workers, and how those would be continued in the institution after the CPRIT funding. For all expansion applications, one of the issues that the reviewer has talked about is they think people assume that they either know or remember about the project. So please don't assume that. There could be different reviewers reviewing your project, or it could have been a year since they've seen your project. So be sure to restate your project and justify and explain in detail your expansion plans and the feasibility of those. This is another item that we ran into. Applicants often report their progress to date, but they fail to include a projection of results in the final year if their project hasn't ended. So be sure to include those projections so the reviewers will know that what your projected final numbers would be. And as I mentioned before, you should have baseline data. 2 resubmissions are allowed under this mechanism as the others, and the recommendation that I give to applicants who have not been successful is to fully address the summary statement weaknesses that the reviewers have presented in those summary statements that you receive after the application review process. As Becky mentioned, the Prevention Review Council is the second level of review, and these are the considerations that they take into account when they're recommending their slate for funding. And Becky talked about some of these. The return on investment is the potential for the impact. And then they look at the portfolio, the current portfolio, and decide on, what is best for the portfolio for geographic distribution and cancer type. And they also look at the type of program that's currently in the CPRIT portfolio. And together they make those decisions and then refer them on to the PIC. This shows the timeline for this current cycle. So for you right now, the very important date is the February 21st when applications are due. Then peer review takes place May, June, and July. And then the PIC meets the end of July, and the Oversight Committee meets on August 15th to consider the recommendations for awards. You all are probably very familiar with cpritgrants.org, but just wanted to show this. Again, you can view the current RFAs there and submit your application, or the RFAs are also on the CPRIT website under funding opportunities. If you have technical questions about the application process, please call the help desk first. Often people call me, and our third-party vendor runs our application process, so I am not as able to help with those questions. So please start with them first, and if they can't answer your question, they will refer you to the programmatic office. This is my phone number, and we have a prevention email address, and then, of course, our website is listed up there. So now it is time for questions, and we already have several that have been submitted. So I will read out the question, and then we will answer it. And if you have follow-up questions, go ahead and type them in. So the first question is, if we already have submitted a grant to continue our program, which includes expansion, can we do this one as well? Would this one then supersede the other, given that it would continue and expand what we are doing, as well as adding another cancer site?
Well, assume from this question that you've submitted something, but you don't know the outcome of that application yet. So you could go ahead and submit a new application. If by chance both were to be funded, I think we would work with you then to somehow combine the two projects. Because if your question says, would you be in the new application, you would be adding another cancer site. So if the new one was different from the one that's under review now and adding a cancer site and both were successful, we would work with you to combine those two.
The question about the counties, must the program be expanded to non-metropolitan medically underserved counties, or can it be expanded to non-metropolitan or metropolitan medically underserved areas within our county?
Well, if your program has proposed to serve a county, say Bexar County, we assume that you are serving the entire county. And so the answer to your question is yes, it would need to expand beyond Bexar County to another county that is either rural or medically underserved.
The question about linkage to treatment. Concerning linkage to treatment, do we need to have access to no-cost treatment options for uninsured clients or those who can't afford treatment? Are we allowed to cover costs of treatment if there are no-cost treatment options available?
Yes, you are required to identify access to treatment for people. The grant itself cannot cover the costs of treatment.
The next question is about the evidence base. What constitutes evidence base? Is the intervention required to be defined as evidence-based by CDC, or can other national organizations signify the intervention as being evidence-based?
We usually look at the intervention itself, say the screening intervention or other vaccination intervention, as something that the U.S. Preventive Services Task Force recommends as being evidence-based. There are other national organizations that whose guidelines might differ a little bit in terms of age criteria, for example, for breast screening. So we will also accept, say, the American Cancer Society's guidelines for screening based on age, but those are evidence-based interventions. And then to the extent that your other activities have some evidence base, for example, your plans for delivering your outreach and education, you should cite those where possible. We understand that sometimes you're taking something that has been shown to work in one setting or one population and adapting it to another one, but you should describe how you're taking that evidence-based intervention and the steps you're going to take to then adapt it to a new setting or a new population.
For Hep C testing, if positive, would the grant cover the cost of treatment, or would we need to find ways to get treatment paid for?
The grant does not cover the cost for the viral treatment for Hep C. We recognize that is expensive, but you should look for ways to provide that treatment. I know some of the pharmaceutical companies have patient assistance programs that can help with the high cost of that viral treatment. You're also welcome to, we can help you contact some of our other grantees who have programs for hepatitis C testing to see what they've done to be able to cover the patients who are positive for Hep C.
There's a question about how dissemination and scalability differs from the overall expansion narrative that would respond to the rest of the RFA section. So I think some clarification on dissemination and scalability.
In terms of how these are different from expansion, yes, it's once you, in terms of dissemination, what are your plans for disseminating your results, disseminating your project, usually towards the end of the project, and also explaining how others might be able to replicate or scale up to do this kind of project. So that really is a different intent than looking at expanding your project. I will look at page 23 and see if there's something else I might add to that point. But why don't you go ahead and look at the next question?
I believe we have answered this question, but we have a current CPRIT prevention project and recently submitted an application to continue once our project ends in May. Are we still eligible to apply for this funding opportunity as long as it includes an expansion of the program? And I believe Becky answered that earlier, that yes, you are eligible and that we would work with you if should both projects be funded, and we are interested in the one that has the expansion. Is it within the eligibility requirements to expand services to a population previously served by a CPRIT funded grant, but not expand the service area? Or must services be expanded and the target population be expanded?
It can be either an expansion of the types of services or an expansion in geography, an expansion to additional counties. So it can be one or the other.
Question about treatment for colorectal cancer, and just in general, CPRIT does not fund treatment. So it is not specific to one cancer type, but these you must identify other sources for treatment. We will fund diagnostic testing if the screening test is positive. If we want to subcontract with another organization to provide some services, do we need to submit a detailed breakdown of those costs and line items? Yes, in your budget justification, you would need to list what services that you are subcontracting, and it's best if you do list the line items at least, and at least an approximation of the cost. There's another question about allowable expenses. Can rent be charged to the grant as an allowable expense? We do now have in the prevention grants indirect costs. They're maximum of 5% of the grants, but it still must be directly related to the project. And so if you have questions about that, I'm happy to take them on a one-on-one basis. Would you recommend an external evaluator? And then related to that, what percentage of the budget should be set aside for evaluation?
Well, the decision about an evaluator is really up to each organization. If you have in-house capability and someone qualified to conduct your evaluation, no. But if you feel like you need some assistance with that, then yes, you should put that into your budget. We don't have a set percentage for what that should be. So again, that's a determination that each program would make based on what they need. So it is, the dissemination of your project results. There are examples given there. Limited may include, but are not limited to, presentations, publications, abstracts, submissions, that kind of thing, and then in terms of scalability, to describe how your project lends itself to dissemination or application by other communities or other organizations in the state. So that really speaks to how someone else can learn about and use your project.
Okay, there's a question about the number of counties that would be considered responsive to the RFA. Must we add more than one county where services will be provided?
We have not set any criteria around number. Of course, we like to see as broad a reach as possible, and encourage you to think about how you can reach as many people as possible in areas of need.
Does a subcontract have to provide clinical services, or can it provide assistance with other types of services, such as enrollment of participants? Yes, it can. A subcontract does not have to provide the clinical services. The subcontract just needs to be well justified in the application and the budget. Can a program focus on serving a medically underserved area in a metropolitan county?
Yes, there are some counties that have, some metropolitan counties that have medically underserved areas within them, so they would qualify. But again, you should be looking at serving the entire county, not just one area within that county.
Are proposals awarded more points for a higher reach or larger impact?
Well, that is definitely one of the considerations, especially at the programmatic level, to see how many people each project can reach. But we recognize that, you know, projects are very different, and some projects that might touch fewer people maybe have a very strong rationale for being and will score very well. But again, you know, we are very interested in reaching the most people possible within these grants.
Question about subcontracting. Can a subcontractor provide the intervention and case management for expansion into another area, or can only medical services be subcontract? A subcontractor may provide the services and case management. We do not, CPRIT does not get involved in the contracts between applicant and subcontractors, but you must adhere to all the rules and regulations that you as the applicant would. Your subcontractor must also adhere to all of those rules and regulations, and you should definitely have a written contract in place with the subcontractor. Would a proposal receive more consideration if it were to expand services but focus on a medically underserved area in a metropolitan county?
The RFA says you can do either expanding services or expanding expanding the counties served. Again, you know, we're interested in reaching as far and wide as we can. So we would always, of course, encourage both expansion of services and expansion of geography. But for now, the RFA calls for you can do one or the other.
But as Becky mentioned earlier, if you're already serving that county, that does not count as an expansion.
So a service would have to be added for that one to qualify.
Are there any budget limitations on equipment and supplies in regards to providing direct services? We don't set limitations on any category. However, one of the considerations that is taken into account is the impact and the return on investment. So the reviewers look at the number of people served compared to the overall cost of the project. We do encourage cost sharing for big equipment. That's not anything $5,000 and above is considered equipment. For other supplies, computers and things like that, those are not considered equipment. Can we expand to a different cancer screening other than what we currently provide?
Yes, that's the intent. So if you're doing breast cancer screening and you want to add cervical cancer screening, that is what we are encouraging, that you use the networks, you use the relationships and the contacts that you have and add services. So yes, there's a list of those services in the RFA that I mentioned earlier.
Do you prefer letters of support that include the value of the collaborators' participation?
The peer reviewers do look for those letters, and I'll tell you they don't like them to look like form rubber stamp letters, but that really do address the role of each specific collaborator and what their role is in the partnership.
Is it more favorable for proposals to target areas identified by CPRIT or target certain demographics identified by CPRIT?
Target areas and demographics to me are, I'm not sure I understand what you mean by that. To me, they're sort of the same. But in the RFA, what we do is we look at the data from the Texas Cancer Registry and identify geographic areas of the state where we see higher incidence and mortality rates. And we also look at the disparities and look at different populations that may be disproportionately affected. So yes, those areas of emphasis, all things being equal, would get higher consideration.
On the issue of letters of support, should these letters include the dollar value of participation, whether cash or in kind? It's not required that they include the dollar value. What the reviewers look for is what is the unique contribution that this collaborator is going to make to the project. Not just that they support the project, but what is it that is going to, how are they going to work with the applicant? And there's a question about links to the maps, that they can be located in the RFA. I will add that before we post the slides. It is not a direct link to the map because you can't directly link to the map itself. You have to go through several steps. So I will include that when we post the slides for the webinar. Do you allow and or welcome visuals in the written proposal? For instance, graphs or pictures?
We allow them. I know the reviewers like to see maps of Texas and the counties that you propose to serve, because remember, these are reviewers from out of state, and that sort of gives them a visual of where your project is and what you're proposing to do. The others, in terms of graphs, are really up to you and how you can best describe and define what you're doing for the reviewers.
Please remember that I am available to answer follow-up questions. And on the screen, you'll see my phone number, and then the email, prevention@cprit.state.ts.tx.us, or we've now changed to cprit.texas.gov, and then we do list our website. But if you have questions, please send them to either my personal email, which is rmagid@cprit, etc., or call me, and I will, if I can answer the phone, I will return your message as soon as possible.
Well, thank you so much for participating this afternoon. And again, as Romana said, don't hesitate to reach out to us with additional questions. We want you to be successful. Our grantees are doing a great job of providing much needed services across the state, and we really want to help facilitate that. So thank you again.
Thank you.